I want to welcome you to our series of seminars/webinars that we have been holding this year. The theme is on resilience. And in that continuing series, I am delighted to have a faculty colleague speak about this important topic. My name is Vishwanath. I'm one of the co-directors of the Lee Kum Shung Center for Health and Happiness. And we also have, happily, Dr. Lara Kubzansky, my other co-director, who just joined us. I want to introduce today's speaker, Dr. Shekhar Saxena. Dr. Saxena is a professor of practice of global mental health at the Department of Global Health and Population at Harvard T.H. He's a psychiatrist by training and has served in the World Health Organization since 1998. He's a global leader on mental health policies. He has held leadership positions. For example, he was a director of the Department of Mental Health and Substance Abuse at WHO. His expertise includes providing advice and technical assistance to policymakers on prevention and management of mental, developmental, neurological, and substance use disorders and suicide prevention. So today, he will be talking about monitoring population-level mental health and well-being, why it matters now more than ever before. This topic couldn't be more timely. So Dr. Saxena will speak for roughly 35 to 40 minutes. If you have any questions, please put them in the chat. We will be monitoring the chat and I can then ask Dr. Saxena to respond to those questions. We'll try to get to as many questions as we can. So Dr. Saxena, the floor is yours.
Thank you very much.
Is yours,
thank you so much, Vish, for inviting me to join this series of webinars. And I'm really delighted to do so, and also for introducing me very generously and kindly. All I can say is that I have been around for a number of decades, and I've seen the situation for mental health and well-being improve almost in all parts of the world. But the pace of that improvement is actually very slow. So my key message will be how we can step up our actions and how monitoring population level mental health and well-being can actually assist us in doing that. And if any of the participants in this webinar can do something more about it, a little more than what they were doing yesterday, that will be worth the time spent. So with that hope, let me start sharing my screen and see where we are on monitoring population level mental health and well-being and why it matters more. And also I'll deal with a little bit about how that can be done. And in the end, I'll talk just a little bit about a project that we are doing, me along with many of my colleagues in global mental health at Harvard, and how the Center for Health and Happiness has been able to assist us in doing that, and what are the prospects of that assisting us in monitoring population level health. I'll begin with the concepts and definitions very briefly, but I think that is quite important because many of these terms are used in a variety of ways and mean somewhat different things to different people. So this is what I would like to use, and I will, having served in WHO for a long time, I would like to begin with the definition of health given by WHO way back in 1948. And we all know about the fact that health is more than the absence of illness. We also know that there is the mental well-being, the physical well-being, and the social well-being. But what I want to emphasize is that these are interacting with each other. So you cannot have a an ideal physical well-being without mental well-being and social well-being, and vice versa. So these are all interconnected, and as human beings, we have a state of well-being that is directly affected by any of these spheres, including social, which is not being talked about so much in the health area, but it's extremely important. And if there is any need to give example, the pandemic is a book example of how the physical well-being of hundreds of millions of people were affected because they got infected. And unfortunately, many millions died in this pandemic. But the social well-being and the mental well-being of communities, of families, have been affected in such a large way. And this is a very clear example, as clear as it can get, that these well-beings, the different aspect of well-being actually, are very much interconnected, and we need to really think about them as a whole rather than consider them separately. Having said that, we will try to focus on the mental health and well-being part of it. Let's go a little deeper into the definitions and concept, and I would like to point out that well-being can be subjective or objective, and these definitions have been directly taken from the work of some of the colleagues in the Center for Health and Happiness. In short, well-being subjective is feeling good, but it can also be assessed as a global assessment of all aspects of life, which includes life satisfaction, positive effect, absence of negative effect, which is different from the presence of positive effect, sense of purpose, positive relationship, and general growth and optimism, engagement, autonomy, and mastery. These are all aspects which in some way combine themselves to have a subjective well-being of the people. And there is, of course, the objective well-being, which is a set of societal circumstances which are more material, more tangible, and more quantitative. That doesn't mean that the subjective well-being cannot be quantitative, but it's just a little more complex to quantify that. But yes, there have been very good attempts to do that. I'll go on to describe a definition of mental health that was given by WHO in 2001. That was after 2 years when I joined WHO, and I was fortunate enough to contribute to that. It is again a definition which is conceptual rather than an actual definition, but it does include the capacity of thought, emotion, and behavior that enables individuals to realize their own potential in relation to their developmental stage. So it's about the potential, it's about the realization of that potential is much more than the psychological functions of thought, emotion, and behavior, which are included, but it's more than that. It's about one's potential. And of course, it will depend on what stage of development you are. But the next part is a little debatable to cope up with the normal stresses of life. What is normal is very much debatable. The people in Ukraine, what they're undergoing, is it normal? Is it the normal stress of life, or is it really abnormal? Is something that we can all debate about. So at what point the boundaries crossed between normal to abnormal is something which is for discussion. But WHO did not do that. But it did include, in addition, to study or work productively. The word productively is also a little debatable. There can be people who can have very good mental health, but are not productive to society. They are not contributing to society, and whether we should call them as mentally not healthy enough is something that is again very debatable. But yes, this is what the definition of WHO is. But I'm happy to report to you that within a few months, actually, by the end of June, they are going to come out with a new report on mental health. And there is already a discussion about to what extent this definition could actually be adapted. And there are some small areas where this is going to be adapted. But yes, it's about psychological functions, it's about potential, it's about coping up, and it's about being productive and contributing to the community. The next concept, which I want to just very briefly describe, is mental health as a dimension, as an spectrum, rather than mental health as a binary between people who are well and other people who are ill. The world doesn't actually behave that way. We don't have a very clear boundary between people who have a mental disorder and other people who don't, because of the positive aspect of mental health. We can be on this dimension on the left side, which is positive mental health. We can have some mental distress, we can have mental disorder, and the prevalence of mental disorders is actually quite high. Or we can have a psychosocial disability, but at every stage of this spectrum, something could be done. It can be promoting for positive mental health, it could be prevention of disorder when people have distress, it could be treatment and prevention of relapse, or recovery, which one can strive for. Again, COVID has given us a book example of how the spectrum is a good way to look at mental health, because people during the pandemic have moved towards the right. If they had positive mental health, they might have some mental distress, they might have some difficulty in coping. I myself have that actually, and I'm sure many of you will identify with that. If we had a mental disorder, then we have more disability. And so this again is a concept that we need to remember, which creates some difficulties in monitoring population level mental health. But let's see how we can still live within the concept of a spectrum and still do some justice to the measurement of mental health and well-being at a population level. That's what we are trying to do. I'll very briefly describe also the WHO's concept of quality of life, which was given by the project WHO's Quality Life Group, which has a number of publications. It's in short called WHO Call. And I was again fortunate enough to contribute to this project in the 90s. It defined quality of life, which is, of course, a subjective quality of life, as individuals' perception of their position in life, in their cultures and value systems in which they live, and related to their goals, expectations, standards, and concerns. Many words, but eventually this is very much a subjective impression, and it consisted of 6, again, interacting domains: physical, psychological level of independence, social relationships, environment, and lastly, quite interestingly, spirituality, religion, and personal beliefs. If you think about WHO talking about spirituality and religion, there is obviously something which WHO will be stopped from doing by all the member states. But we did manage to actually include this particular domain in the quality of life concept that was given. This project is dormant now, but the instrument that this project gave are very widely used even now. So having done that, I want to come back to the Sustainable Development Goals of the United Nations, which in 2015, for the first time, included mental health and well-being as a part of it. And the target 3.4, as all of you know, includes promote mental health and well-being, which is a very good thing to happen, but it also puts the burden on measuring the mental health and well-being, which obviously we are trying to do. Not ideally, but definitely we are well on our way to do that. The indicator that was included by the SDG group is actually just one out of some 267 or some indicators. It's suicide mortality rate, which was included, which obviously has some value, but it is also a lot of limitations. So we will, of course, discuss the suicide mortality rate, but we will go beyond that and say, how can we do better than what SDG decided to do? So to deal with suicide, the numbers are very high, more than 700,000, in fact, 780,000 deaths every year, one death every 40 seconds. And WHO is very active in monitoring the suicide rate. It is based on the information that the countries provide to WHO as a part of the mortality data, but WHO also does some modeling and some more work to arrive at the global health estimates related to suicide, and it produces booklets like what I have projected on this slide, and you can create maps, you can create charts, and so on. It's a very rich data set, and it is updated every 2 years, I believe, on the website, and the reports are published every few years. And so this is a very rich source and very good source, reliable source of suicide rates. And just to give you one graphic, overall the suicide rates have been coming down in the world. In fact, there has been almost a 10% decrease since the time the WHO started measuring in earnest in the last, say, 8 years or so. And you can see in all regions of WHO, suicide rate has been going down except one. And if you can look at the orange bar in between, that is the one which belongs to the Americas, where the aggregate suicide rate for the region has actually gone up. So overall, globally, it's going down. But for some countries, and at least for one region, it has been going up. Let's look at the CDC data for the US. And suicide rate over the last 20 years has actually gone up quite considerably. So it is starting from, for example, for the men and women, from 10.5 to 13.9, and even for women, where the suicide rate generally, mortality rate is low, it has gone up from 4 to 6, which is actually 50% rise, which is very, very unfortunate. Women compete with men in many areas, but sadly, in some of these areas, which is very unfortunate. And so the US is one of those countries where suicide rate has gone up considerably. And compare that to China, where the suicide rate, although on the higher side to begin with, has gone down considerably in the last 20 years. So these are the kind of examples where the global suicide rate can be measured with some benefit, but it's much more useful to measure the regional and the country. In fact, one should go down to the communities to look at suicide rate, and that can be definitely one of the measures of population level mental health. And when I say populations, I mean even the age groups, where suicide rate amongst the young people have actually been going up, including in the USA. And if you look at the age distribution, even as young children, as between 10 to 14, are dying because of suicide. And although in young age groups, death is an uncommon phenomenon, but suicide as a cause for death is there at the rank between 2 to 4 for all reasons for death. So it is really something that we need to watch, something that we need to track, and then use for suicide prevention activities, which is what the use of the monitoring systems are. And so this is an area of concern for that. Suicide rate is accepted by UN as a monitoring mechanism. We have to use it, but there are many limitations to that, especially when we are talking about the broad concept of mental health and wellness. There is definitely an underreporting, much more in lower and middle income countries. There is in India, for example, the estimated underreporting for suicidal deaths is between 20 to 40%. So actually the rates are much higher than what the official rates are. There is delayed reporting. Many countries take number of years before they report it. There is also inaccurate reporting because the suicidal deaths, although deaths are very easy to check and monitor, but still many countries don't do that very, very well. Not all suicides indicate a mental disorder, presence of mental disorder, although one can argue that most of them or all of them do include mental distress. And suicide is a final outcome and does not capture lesser distress, which is where we should be going actually. Its sensitivity to change is limited, especially over shorter periods of time, and attributing causation to the determinants of suicide is difficult. and attributing impact of public health intervention is also difficult. For example, in China, which I showed an earlier chart for, it is very doubtful whether the mental health interventions actually gave rise to the decreasing suicide rate. It's much more the larger socioeconomic determinants which gave rise to that, especially transition from a rural to an urban environment, which is what is believed to be the major reason why China has much less suicide rate. Now, moving on, measuring the extent of anxiety and depression on a population level has also been used very commonly for monitoring mental health and well-being. Although it's just the opposite of that. What we are doing is to check whether people have anxiety symptoms and depression symptoms, and then extrapolating that to see whether people have good mental health. And the underlying hypothesis is that if a person has anxiety and depression symptoms, then their mental health is in some way compromised, which is a fair assumption, but not completely an ideal assumption. And some of the instruments used are PHQ-9 for depression, GAD-12 for anxiety, PHQ-4, which is a very short instrument, just 4 questions. 2 of them are for anxiety and 2 of them are for depression, or GHQ, which is the general mental health symptoms. The advantage of using them are that they are well standardized all across the world in many cultures. They are, of course, culturally valid. They take a short time and effort. Results can be compared across populations and time, but certainly, as I was explaining earlier, they measure symptoms and not mental health or well-being. So there are major limitations in doing that, but still they are being used very commonly. And just to give an example, they're used by CDC for reporting frequency of symptoms in the last 7 days. And these kind of charts, especially during the COVID period, have been extremely useful to track population level mental health and well-being. In this chart, there are many things that can be said about, but there are definitely 2 observations which I want you to notice. One of them is that the anxiety and depression level over this period of time, which finishes in January 2021, but subsequently also there are data, the anxiety and depression symptoms have remained about the same. They have not decreased. So even if the pandemic was continuing, the anxiety and depression symptoms are also continuing. And the second observation is that the different lines here indicate the age groups. And there is a very clear pattern. The younger the people, the higher is the anxiety and depression. And it's not only because of a reporting bias. Young people are actually much more affected by the pandemic, and they're reporting much more anxiety and depression. And this pattern is fully sustained over a period of time. So the red bars at the top are the young people, and at the bottom are the oldest people. So actually there is a very clearly discernible pattern in reporting anxiety and depression, which is again something which is very remarkable. And unless we did this kind of monitoring, we were not able to check what is happening to different age groups. I was part of a study which is still unpublished, but I just wanted to present the fact that exactly the same pattern has been seen in all the 28 countries during 2021 for self-reported anxiety and depression. And in the United States, again, it's the same pattern. Although the dispersion is very high, the variability is very high across the populations, but the pattern is the same, that the anxiety and depression levels continue unabated during these periods of time. And again, the same pattern, that younger the people, which is on the left side of this, on the bottom is the age groups, the higher the anxiety and depression symptoms are. And this chart also shows a slight pattern in women reporting more anxiety and depression compared to men, but that is variable according to the country that you will live in. There is also the use of well-being and happiness measures, which obviously is perhaps the best way to do that. And including in the center and many other people are using this kind of ladder where you ask people where they are on this ladder, on a scale of 0 to 10. Are they thriving? Are they struggling? Or are they suffering? And this is again a very short instrument. It takes very little time to do that and gives a wealth of data on how people subjectively assess their well-being. This has been very commonly used, and this has been used to make happiness scores for the countries. And this kind of charts where it attracts a lot of attention in the public, that which country is the happiest and which country is the unhappiest. Although there are many ifs and buts, but still these are very commonly used. And the World Happiness Report, which is now in its 10th year of publication, publishes these charts very frequently based on the Gallup data. And Finland came out to be at the top, and US is not in the first 10, but it's at the level of 14, but still is doing pretty well on that. So these kind of measurements are very commonly used, and these kind of maps, which I show now, excite a lot of attention, and people look at it and do that. My own feeling is, and I'm very happy to be corrected by Vish and Laura, is that there is not too much of a value in comparing across countries, but there is certainly a value in comparing across time. But that's something that we would perhaps want to come back and discuss that. But yes, there is a very commonly used method and commonly arises a lot of interest. So going along, why we should be measuring and monitoring mental health and well-being, and why it is important now. Well, measuring mental health is at least as important as measuring any other component of health. That's what my beginning point is, and that needs to be done. And I must say that measurement of mental health is actually not as well being done as other areas of health. Measurement also gives a possibility to compare it across population and across time, as we were discussing earlier. It helps to identify population groups at high and definitely also at low risk. It assists in identifying determinants of mental health and well-being, the risk and the protective factors, and it allows for identification of social, economic, and health policies to protect, promote, and enhance mental health and well-being, and to prevent mental disorder. So action is the final objective of measurement. Measurement not for itself, but for action. And that's where mental health and well-being need to be measured. And it also allows research for evaluation of existing and newer policies for their effectiveness. There are 4 reasons why I believe that it is even more important now to monitor population level mental health and well-being, although, as I said earlier, it was always important. The first one is increasing inequities. Second is the pandemic, of course. The third is the humanitarian emergencies, and then the climate change. Let's very quickly go through some of these materials. We know that societies have always been unequal and so, but in the last 20 years or 30 years, the inequities have actually increased. And I'm very perturbed to present this chart because the top country which showed the highest amount of increasing inequity is India, my home country. But many other countries are showing exactly the same pattern, that inequities have been increasing over this period of time. And inequities directly go towards increasing the mental health problems and impact on well-being. So definitely there is reason to measure that, as some of the major work in the past 20 years has suggested. The societies which are more unequal have more problems, including very basic things like life expectancy and literacy and homicides and other things. But it also includes mental illness, including drug and alcohol addiction. And this chart gives you, just for a few countries from the OECD countries, a linear relationship, well, almost a linear relationship between an index of health and social problems and income inequality. Income is only one of those, but yes, there is very clearly a relationship. And we do know that income inequality have been increasing over the period of time. The second reason for why we should be doing that is actually COVID. We are all affected by that, and the socioeconomic factors are much more than actually the physical factors. Things like job and financial insecurities, the stress of working from home, studying from home, disruption in medical treatment, school and college closures, social exclusion, bereavement, many other factors which give rise to increased impact on mental health and well-being that most of us are facing. And this has also been documented by all the kinds of surveys that have been done. There are literally hundreds and thousands of surveys which have been done. Here I present just findings from a few countries where pre-COVID versus post-COVID, the symptoms of depression were increasing at a very substantial pace. And as I explained earlier, they're not coming down any longer. So they're not coming down in spite of the duration of 2 years of pandemic. So there is something to worry about there. The third reason I believe why we should be measuring much more than now is the fact that humanitarian emergencies have increased in the last 10 years much more than earlier. People who are forcibly displaced, for example, worldwide is now 84 million, which is a very large number. And it's now increasing also because of conflicts and wars, as we are seeing currently in the last few weeks' time. And these people who have been forcibly displaced or have undergone a natural disaster or living through conflict and wars are definitely at a much higher risk of having their mental health and well-being compromised. And something needs to be done about that. So we do need to measure some of these things very clearly. And there is definitely the last issue that I want to mention is that definitely climate change is one of those things which is going to affect our life in a very big way, but also our mental health and well-being. There is definitely evidence of substantial mental health impact of climate change and other environment-related determinants on suicides, on depression, on things like post-traumatic stress disorder. There's also a concept of eco-anxiety, and also increased incidence of extreme weather events and associated impact on mental health. There is certainly an evidence for positive mental health impact on by green spaces and exposure to nature, which again is something that we might like to utilize. There is a lot of literature on that, but this is definitely one of the reasons why we should have that. Just this morning, I read a report on saying that no country has met the WHO air quality standards in 2021. And we do know that air quality standards have a direct impact on mental health and also on the development of children. So it's not only our lungs which get affected, it's our minds and our brains which get affected by that, and we need to measure those things. In the last maybe 3-4 minutes, I want to just introduce some of the work that we're doing in our group now. Some of us joined together to write a Lancet Commission on Global Mental Health and Sustainable Development, which was published in 2018. And it was a long publication, 25 pages or so. But one of the recommendations was to strengthen monitoring and accountability for global mental health. And we took that seriously and started a project which is called the Countdown Global Mental Health 2030, which is in keeping with the Sustainable Development Goals. And we, a few months back, late last year, we published a dashboard, and I'm giving here the URL for that, which is for the countdown data. Now, what are these data? It's a dashboard for all countries. It's a global data set, so all countries are there on where they are on their mental health. It is aligned to SDGs. It has multiple partners. It has WHO and UNICEF as partners, but also a number of non-profit organizations, and Lancet is obviously also a partner. We collect data from multiple sources. These are all data which are there. So it's a secondary collection and aggregation of data and not primary surveys. And we do periodic reporting of results. We did that last year. And this kind of exercise, we believe, can be very useful for monitoring mental health and well-being at a country level. Obviously, that has its own limitations, but at least at that level, it is of some use. We identify a number of indicators and arrange them into three domains. The determinants of mental health, the factors shaping the demand for mental health care, and factors shaping the strength of the mental health care system. We believe all three of them are important, and there are existing data sets that we tapped into. And we created this dashboard with 53 indicators especially for mental health of children and their care providers. I'm sure you cannot see this, but you can go onto the website and check that. And you can also play around with that to create on your own maps, your own charts, your own tables, and so on. So this is something that I just want to open up to say, this is something that we are ongoing work. And the Center for Health and Happiness has actually assisted us in developing these kind of dashboards. And we are in the process now to include the happiness ladder score as one of the well-being measurements, data directly derived from the Gallup World Poll and the World Happiness Report, which we talked about earlier. We considered some other indicators, but we found that perhaps the coverage of data is the largest for this kind of indicator. So we are going to include that and publish some of these results later this year, so that it will truly become a mental health and well-being measurement rather than just a mental health well-being, mental health thing. So I've taken about 35 minutes or so, and I stop here, but we'll be very happy to discuss, answer questions, and also get further knowledge and information from the co-directors of the center, who are both here. Thank you, and back to you, Vish.
Thank you so much, Shekhar. That was wonderful. As you can see from the reactions in the chat, people really appreciate the broad picture you painted. I think it's like a tour de force. You have to cover the entire world here. So really appreciate it. So questions are coming up. So just to remind people, if you have questions, please put them in the chat. I will be reading them. We will be monitoring the questions, and we can ask Dr. Saxena these questions. So Shekhar, I want to start off with one question, and then I can go to the chat. So the question I have, as people are adding questions, the question I have is about data absenteeism. What I mean by that is, we generally, we measure what matters. So when we measure, we directly or indirectly indicate what matters in life or in a country or a society. And most often we don't see data from poorer countries on poorer people, people from poorer socioeconomic, lower socioeconomic status, et cetera, right? So I'm wondering, as I was looking at the data, I also was wondering, are there challenges with this problem of data absenteeism, and what can we do, because that's an important indicator should you want to take some policy decisions, I think, right?
Vish, you are asking a question that we are all struggling with, obviously. So our approach, and when I say our approach, it is the approach of the Countdown team, but also in the past, that was the same approach that I and my colleagues in WHO followed, is that, and also I'm touching upon some of the comments on the chat about the data generalizability also. We do know that cultures vary, and data absenteeism, especially from those people who are less able to report, and those countries which are less able to report or less willing to report actually have a problem. And so there could be a bias definitely there. Even on our Countdown dashboard, you will find that from many countries, the data are missing. But we were actually surprised that the international and global mechanisms for data collection are actually quite robust. So we've collected data on 57 indicators, and the data is absent for say 30 or 40% countries just for about half the indicators. So we were actually pleasantly surprised at the presence of so much data, but obviously data absenteeism is there. What I would say is that even in the selection of indicators, we followed the line that there are some indicators which are so valid and so predictive and so important that they need to be included in any case, even if the data coverage is not very high. But for many other indicators, and also on those indicators, we thought that we could shame countries in collecting those data, because when they see the dashboard and they find that their country is a missing data, they will perhaps make an attempt to collect the data. And the same thing happened in WHO. When we started the Mental Health Atlas way back in 2000, we had very poor data. But over the next 6 iterations of the Atlas, the last one being published in 2020, the data has improved a lot because countries realized that somebody is asking for the data and they started collecting. So things are improving, but yes, the message is that for those indicators which are extremely useful, we need to present them and then encourage and strengthen the capacity of the countries and communities to collect those data. There are some indicators which are much more culturally sensitive, and so there could be questions about whether the data is valid for those indicators, and there are some ways around that. But yes, these are population level figures, and there is always an approximation that you're making. My point is not that the data is absolutely fabulous or ideal. My point is, are the data being useful for practice and policy? And the answer is a clear yes.
So on that issue, actually, because it is so critical for policy, that raises a whole host of issues. And one question that's been put in the chat, which I thought is an interesting question, is, so you presented these charts, especially on the latter half of your presentation, when you clearly showed, whether it is gross national product or domestic product or whatever indicator of socioeconomic development you take is strongly correlated or associated with better mental health. So one question that's being asked is, what are your thoughts on allocation of resources, when you monitor these things? If resources should be used to improve general quality of life of societies, considering that improvements on inequities impact mental health well-being, or on to target specific issues or high-risk populations, right? It leaves a kind of an interesting choice from the data. So what do you think?
Well, Vish, I will begin by saying that I'm a mental health professional. So for the initial 20 years of my life, I thought that mental health and mental disorders must get more resources, which I still believe now. But I think the equation is much larger than that, actually. And so most of the evidence-based interventions for preventing mental disorders and improving mental health and well-being are actually outside the health sector. They are in the area of socioeconomic determinants. The World Bank has its objective to remove extreme poverty. Now, WHO is not going to be competing with the World Bank on removing poverty. Neither are we. So our attempt as mental health professionals or health professionals in general is to indicate and provide links as to why this is so important, but not actually ask for those things to be done within the health sector. So we have a larger responsibility to society where we must provide those kind of evidence and data to say that poor people have poor mental health. It's not that all the money needs to go for poverty alleviation. There is definitely advantage in that. Also for education, for example. That's how SDGs are such a good framework, because they're all interactive between them. And our task, I see, as pointing out the links and the benefits of doing that. The resource allocation is not on which I am expert in. So I would leave it to the experts to do that. My task is to provide the data and the information so that society, in some cases the politicians or developmental agencies, can actually decide on the resource allocation in the best possible manner. I would just add that over the last few years, I am increasingly impressed by the returns on investment, both for mental health interventions, but also for general socioeconomic interventions. Just take the example of USA providing a lot of financial support during the pandemic to the families. And one of the largest impact of that is that child development has actually improved. And that's going to have dividends over the next 20, 30, 40 years. I would say this is a fantastic investment. And I didn't ask them to do that, but they did it. And it's very useful for us to see and measure how much that has been a benefit. So I'll stop there.
Thank you. The next one is a very specific question. Is the WHO aims still a reliable tool for mental health indicators? You have spent time there, and I think that's very much in your realm.
WHO aims, which I began sometime in 2004, I believe, is still a very valid instrument. But let's realize and it's being used also. Let's realize the limitations of that. It just goes into mental health services and systems. It doesn't go outside that. But for that, it is a very useful tool. And more than 100 countries have actually used this tool. And all the reports are available on the website, WHO website. So my answer will be a very clear yes, but it doesn't measure mental health. It measures mental health services and systems. And it certainly doesn't measure well-being.
Thanks, Shekhar. So, there's an interesting question again on measurement. So questions are coming up on measures and measurement here. Having standardized tools are great for comparing results globally. The question is there a place for localized instruments in informing policy and relevant interventions? I think
the answer is absolutely yes. The answer is that absolutely yes, for several reasons. One of them is that there are limitations as to how the global indicators could actually be applied on local population. And I'll just give you one example. The indigenous people have a concept of mental health and well-being, which seems to be very different from the global standards. So you can't go to that population and apply the same tools, but for many other populations. But the second reason is that the country politicians and sometimes the local politicians will always look for data which is on their population. So you can't use the global indicators and the global data set to convince them. So from a conceptual viewpoint, but also from a very practical viewpoint, there is a place for local instruments and local measurements and local reports.
So the third question, which is focusing on one of your statements, I think, about longitudinal data collection to track what's happening over time. And the question is, it's useful to compare across time, but this relies on the scale used to measure being the same across a significant span of time. Does this create some inertia in preventing the creation of better scales and measures? Will we still be using the PHQ scale in 10 years? If not, how can we compare the depression levels from now to that of 2030?
Very smart question, I must say. And I concede that there is an unintended consequence of that, because people want to use the same instrument and that actually retards the process of making the instrument better. So yes, absolutely agree. And I know that time is going by, but I just wanted to also say in response to a question in the chat that there is certainly a role for storytelling and qualitative data. So my topic was more quantitative, but I must say that both quantitative as well as qualitative data are equally important and they need to be emphasized.
Great. Thank you, Shekhar. That was wonderful. Laura, do you want to say anything, a final word on this? Not to put you on spot.
Well, no, I mean, it's really great to hear the talk. I think the thing I keep wrestling with that I'm curious to hear your thoughts on, and then we'll say thank you, is you touched on it briefly of how you persuade places to monitor. So, you know, the US actually does a very poor job of monitoring mental health. In fact, we don't actually have any terrific instruments. And then, as you've mentioned, to monitor well-being beyond kind of anxiety and depression more limited. So I was just wondering how you talk to policymakers. I mean, I know you said if you put it up there, they know that people are going to ask, but I'm not convinced that, you know, everyone is so motivated by that. Do you guys have sort of tactics for convincing people that this is worthy of monitoring?
We have no magic wand to do that, and we keep trying, and sometimes we succeed, sometimes we don't. Some of the countries that have done much better than USA are UK, which is systematically monitoring well-being as a policy direction, and also currently New Zealand, which actually the Prime Minister herself is very interested in well-being, and they're doing it very systematically. So we just present some of the good examples and try to persuade. But yes, it's an uphill battle, certainly.
Right. And then the related battle is, you know, even if you monitor it, you know, being willing to do something about it, I think is, of course, the next frontier. So those are the things we think a lot about in terms of, you know, how to proceed. But thank you so much for a really wonderful and rich presentation and a lot of food for thought. And I know some people have asked if the slides will be available, and we do record all the talks, so they will be available for folks to see in that form. And, you know, just thank you so much for taking the time. Vish, do you want to close out with anything final?
Yeah, that's it. I think, you know, thank you so much, Shekhar. That was extremely interesting and provocative. As you can see, there's a lot of interest in this. So for future events, and I also want to thank the audience first for joining us. Please visit our website. Melia has put our URL for future events. We have other webinars, scheduled. So please feel free to stop by our website. There are also many resources on the website that people can use. So Shekhar, again, thank you so much again. And thanks everyone. Bye.
Thank you.